bit. Okay, now these guidelines say that it is more important to prevent infective endocarditis. Unlike the patient having a bad oral hygiene and you giving injection for or antibiotic before doing any procedure, it is good for these patients to keep the oral hygiene maintained. So, general measures to prevent infective endocarditis. Data to support antibiotic prophylaxis are limited, and many cases of infective endocarditis are not preceded by a procedure. Therefore, general preventive strategies and early recognition and treatment of infective endocarditis are far more important. All people, but particularly those with cardiac abnormalities, what we discussed with cardiac prosthetic valve or material or in previous history of infective endocarditis, should practice good oral hygiene and have regular dental checkups with preventive dental and periodontal treatment to ensure optimum oral health. For people with a cardiac condition, which were discussed above, or any form of native valve disease, following preventive strategies are recommended. Twice yearly dental examination and scaling, timely treatment of all bacterial infections, particularly those caused by Staph aureus or streptococci, avoidance of intravascular catheters and invasive procedures unless necessary, strict adherence to protocols for managing central and peripheral intravenous devices. Then we have active discouragement of tattooing, piercing, tongue piercing, which comes under dentoscope, and intravenous drug use. Any unexplained fever should be investigated in patients with cardiac condition, which are listed in the box. That means prosthetic cardiac valves and previous history and such, because it could be a sign of infective endocarditis, and refer the patient to their medical practitioner. So wherever it is a risky, we find it is, we speculate or anticipate any fever or anything, which is, and these patients have a history of heart valve placement, refer them to medical practitioner. Now, approach to endocarditis prophylaxis for dental procedures. If we want, the patient is having these coinciding factors from box 24 and 25. So how we would give antibiotic? Bacteremia associated with dental procedures usually involves viridans group of streptococci, which are known to cause infective endocarditis. Traditionally, the presence of significant bleeding associated with dental procedure was assumed to be an indication of bacteremia and hence need for prophylaxis. However, studies show that bleeding is a poor indicator of bacteremia from dental procedures. So blood doesn't mean high load of bacteria present. They say a very important finding here that self-performed oral hygiene like toothbrushing, flossing, use of oral irrigators can produce similar incidence of bacteremia to that caused by most dental procedures, excluding extractions. So a brushing activity is similar, maybe similar to, restoration placement. As these activities are performed more frequently than dental procedures, they have potential to produce regular episodes of bacteremia. So bacteremia from self-performed oral hygiene is strongly associated with poor oral hygiene and gingival disease. Therefore, it is of large importance to maintenance of the good oral hygiene is more important than using antibiotic prophylaxis for general measures to prevent it. Dental procedures are generally of longer duration than self-performed oral hygiene, so expose patients to a longer duration of bacteremia. Antibiotic prophylaxis is therefore warranted for some dental procedures for high-risk patients. So it is not just 2 minutes if we are doing impaction surgery. And in high-risk patients, we are then covering with antibiotic prophylaxis. And endocarditis prophylaxis is recommended only for patients listed in the box who are undergoing gingival periapical tissue perforation of oral mucosa. We discussed it before. Other dental procedures do not require endocarditis prophylaxis. Surgical antibiotic prophylaxis may be indicated if endocarditis prophylaxis is not for surgical antibiotic. We have read it just before. What is the regimen for this antibiotic prophylaxis? If after careful evaluation of both cardiac condition and the dental procedure, so box 24-25 coherent, antibiotic prophylaxis is considered necessary, give a single dose of antibiotic before the procedure. There is no proven value to giving a dose after the procedure. And if a patient is having more than one procedure requiring antibiotic prophylaxis, dentist should plan the treatment so that all the procedures can be completed in a single setting. For example, scaling and a filling together one can do, or at the most 2 sittings to avoid need for multiple antibiotic doses. Antibiotic prophylaxis use amoxicillin 2 gram orally 60 minutes before the procedure. And that is the dosage. 1 dose is more than enough. You need not give after dental procedure again. If oral administration is not possible, you can give intramuscular 2 gram 30 minutes before the procedure, or IV within 60 minutes before the procedure, or ampicillin intramuscularly can be given, or ampicillin 2 gram IV can be given. Next is, if the patient is hypersensitive to penicillins, then you will use cephalexin 2 grams 60 minutes orally before the procedure. If oral is not possible, then cefazolin IM 30 minutes or cefazolin IV 60 minutes before the procedure should be given. Then patients with immediate, non-severe or severe delayed hypersensitivity to penicillins, clindamycin 600 milligram orally 1 to 2 hours before the procedure can be given. But if it's not possible, again, clindamycin 600 milligram, you will give IV within 120 minutes before the procedure. So amox, first line, ampicillin, second choice. If amox cannot be given, delayed non-severe hypersensitivity, we will use cephalexin, or if oral administration not possible, cefazolin. Immediate severe type of hypersensitivity, clindamycin is the drug of choice, oral, then if not possible, IV. There is some evidence that moxifloxacin may be used as an alternative to clindamycin for patients with immediate, severe or non-severe or delayed hypersensitivity to penicillin, but it's not validated. So stick to clindamycin 600 milligram in immediate or non-severe type of hypersensitivities. This completes our antibiotic prophylaxis need. And okay, if the patient was already having antibiotic for some purpose, in patients like rheumatic heart fever, they will be on a long-term benzyl penicillin medicine. Evidence suggests that amoxicillin susceptibility of viridin streptococci in the oral flora is not significantly affected by benzyl penicillin prophylaxis. So experts say that amoxicillin is appropriate for them also, for these patients also. But in contrast, patients currently taking or who have recently taken a course of beta-lactam therapy, evidence suggests that amoxicillin susceptibility of viridin streptococci may be affected. So therefore, non-beta-lactam antibiotic like clindamycin may be considered. So if a patient was having benzyl penicillin long-term short dose, give amox, nothing to worry. But if the patient has just completed 5-day course of amox in the last some period, then you can go for clindamycin because to top up. But above here, it was written if it was there was one statement of even if it is patients who have recently received surgical antibiotic prophylaxis, okay, for surgical antibiotics prophylaxis, there is no need to modify antibiotic choice, even if using same antibiotic each time. So that was every time the patient is coming, say, for once he came for subgingival scaling, next time he came for some other periapical surgery procedure, you would give the same medicine. That means here. But if a patient has taken short course of antibiotics for an unrelated illness within the preceding 4 weeks, there is no need to modify antibiotic choice. If it is some antibiotic for some other disease. But here we say that if the patient is, the guidelines say that if the patient has had for some other reason amoxicillin itself, then we need to change. Is it clear? If the patient was having, say, some infection in the toe, for which the patient had amoxicillin in this time range, then you can change to clindamycin. But if the patient for the toe had, say, flucloxacin, or the patient would have had doxycycline, tetracycline, then your choice will remain amox. They have not specified in the previous sentence about the patient having what type of antibiotic. Any type of antibiotic, we can continue with amox, but the patient having recently a course of beta-lactam, that means amoxicillin susceptibility may be affected, and then non-beta-lactam, that is clindamycin, should be considered. Is it clear?
Yes, ma'am.
Yeah. So this completes our antibiotic prophylaxis. Next, we will begin with local anesthetics in dentistry in the next session. Okay.
Okay, ma'am.
Thank you.
Thank you, ma'am.